Welcome, everyone. I'm Dr. Tuba Ali. I'll be moderating today's session, and with us we have Dr. Maria Tariq, sessions facilitator. So, today is the second session for liver SBRT. We have with us Dr. Muneeb, and before formally starting today's session, we will start with recitation of Holy Quran. I would request Dr. Bilal Ahmed to please recite few verses.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الرحمن علم القرآن خلق الإنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان والأرض وضعها للأنام فيها فاكهة والنخل ذات الأكمام والحب ذو العصف والريحان فبأي آلاء ربكما تكذبان. Translation. The most beneficent Allah has taught you mankind the Quran by His mercy. He created man. He taught him eloquent speech. The sun and the moon run on their fixed courses, exactly calculated with measured out stages for each. And the herbs or the stars and the trees both prostrate. And the heaven he has raised high, and he has set up the balance, in order that you may not transgress due balance. And observe the weight with equity, and do not make the balance deficient. And the earth he has put for the creatures. Therein are the fruits, date palms, producing sheathed fruit stalks, enclosing dates, and also corns, with leaves, and stalk for fodder, and sweet scented plants. Then which of the blessing of your Lord will you both jinn and men deny? صدق الله العظيم.
Jazakallah, Dr. Bilal Ahmed. We will be formally starting our session now. Dr. Muneeb Karim is a research fellow at McGill University, Montreal, Canada, and his areas of expertise include neuroradiation oncology, stereotactic radiation, and genitourinary oncology. In the previous session, we discussed a few of the parts from the learning objectives on liver SBRT, which Dr. Muneeb covered were applied anatomy for a liver, and along with that, we did a bit about the indications for liver SBRT in metastatic scenarios and primary scenarios. We did a bit about the role of liver SBRT as bridging therapy. Today, we'll be continuing with rest of the learning objectives. And over to you, Dr. Muneeb. And we will be starting with this. And also for all the participants who have joined us, thank you for joining. And after the completion of session, we'll have a small post session survey. and I'll be posting the link in the chat box as well. And for all those who weren't there in the previous session, I'll be posting the pre-session survey link in the chat box. So I would request all of you to kindly fill that. Thank you, Dr. Muneeb, for taking out time and enlightening us with some practical aspects of liver SBRT. Over to you.
Assalamu alaikum.
Walaikum salam.
Can you hear me?
Yes, Dr. Muneeb, you're audible.
And is my screen visible?
Yes, it's visible.
Okay. So as we discussed last time, we reviewed the literature and indications of liver SBRT and indications and placement of liver SBRT in the guidelines. So today we will be covering the learning objectives related to the practical aspects, and I will be sharing my experience that what I have learned and what we are doing over here. So I will be discussing those things with you today. So, these were I divided the learning objectives into components related to simulation, planning, and dose prescription, and the other one is the follow-up. So these are the learning objectives that were sent to me, and these are related to the simulation process that includes that how multi-phase CT, 4D CT are used to guide radiotherapy planning, principle and clinical importance of multi-phase contrast enhanced CT scan, the treatment planning process, and planning techniques for SABR, including patient immobilization, what's the role of burst tracking technique, and discuss treatment planning challenges, including motion management of the hepatic lesions, and the use of fiducial markers, CBCT breath holds, and what is your preferred method. So I can explain only my experience, what I have learned today related to these learning objectives. Before going towards that, if you look into these three images, I think I also showed these images in my previous presentation, that what lesion is amenable to SBRT and what type of dose we are going to prescribe. Is there any difference based upon the location in terms of dose prescription or in terms of surgery, in terms of RFA? Again, these patients are referred to radiation oncology when we discuss these cases first in a multidisciplinary tumor board setting. So if these three cases come to us and they ask you to plan for SBRT, what will be our doses? And is there any difference based on the location? So we will discussing that part, and I will be showing some cases at the end of my presentation. So the importance of CT in identification of tumor is very important for the in case of hepatocellular carcinoma and also metastasis. So we use different CT to identify those lesions. Usually the hypervascular tumors, just like the HCC, they are more enhancing when they get blood supplied to the hepatic artery directly, while the rest of the liver, the normal liver, gets its blood supply from the portal venous system. So that's why these tumor enhances of the arterial phase. In the rest of the when the uh, rest of the normal liver takes up the contrast. So usually in the later phases, these tumors becomes hypodense. But in that phase, those tumors who are hypovascular, then they can be delineated on those phases. And usually in this portal venous phase and other phases, metastases are more visible in those phases of the CT scan. So that's why multiphasic CT is very important, especially in the delineation of the tumors in the liver.
whether it's a primary HCC or liver metastasis. So we have to correctly identify the lesion based upon their uptake and phase. The other part is the uh, motion, because we know the liver moves with the respiration. We want to basically cover tumor adequate with the adequate dose, and we want to avoid the disease relapse. So if we do not cover tumor adequately, so there are chances some cells are not getting uh, targeted dose. So in the future, we will see the near misses around the tumor. So that's why we need to incorporate tumor motion and need to control the motion in terms of different techniques and facilities available to us. And also with this, we can deliver safely treatment to the patient while sparing the OARs. So most commonly, systems used to reduce the impact of the tumor is the 4D CT based ITV. It means the patient specific treatment volumes are controlled and we observe tumor motion based upon the 4-dimensional CT. We can also use abdominal compressional method to force the amplitude of the breathing, and breath hold methods, and the other is the fiducial marker placement or real-time tumor tracking. So these are some techniques that are used to control the motion and identify the motion of the tumor. In the real-time tracking in the Linux, it's usually the fluoroscopy-based system tracking system or the fiducial marker. Usually, all those cyberknife cases for people who are treating on cyberknife. So we need to place fiducial markers around the tumor, and cyberknife tracks tumor based upon the location of those fiducial markers, and it takes around 50 images after every certain time, 15 to 20 seconds, and based upon that location, real-time guidance, it treats the tumor. We do not have the facility of CBCT. We cannot look into the tumor, but based upon those fiducial markers, we see the real-time tracking on the cyberknife. The other system was through the electromagnetic detection, that is the calypso system, in which the fiducial are placed inside the patient's body, and real-time system tracks the movement. I don't have experience with that. There's also technique available through electromagnetic radiation. So why do we do 4D CT scan, and why it is important in this area, in these areas? It's important because with the conventional 3D planning, in which we do not incorporate movement, so we could get these type of images, blurred images, distorted images, and we might miss some areas of the tumor. But if we control the imaging and we do the gated images, we could clearly delineate and see the range of the motion of the tumor, and also it will help us guide the treatment. The other techniques are the breath hold, which is usually regularly done in the left breast cancer, that is the DIBH. And the other method to control respiration is the active breathing control, in which is done through the spirometry, and patient is given a screen and patient can control basically movement. Okay. So this is basically the breathing cycle, and the 0% corresponds to the inspiration, and the 50% corresponds to the full expiration. So it's not it's a usual breathing, normal breathing cycle. It's not the forceful breathing cycle we are talking about. So that's these are the some percent numbers we need to keep in our mind. And one of the method to reduce the respiration is to use the vac lock and abdominal compression method. These are some pictures showing the abdominal compression with the vac lock. and we could see it's quite a lengthy process and it takes time. And the other system is this one, which we use arch shape placed on the board, and we use a plate to forcefully compress the patient's belly to limit the movement during the respiration. So depending upon the availability of these techniques, we can incorporate in addition to the 4D CT to minimize the motion during the planning process. So what is a 4D CT basically? It is a 3D CT, simple, but with 4 dimensions, that's the time. Basically, a series of 3D images of the same volume are taken, and each cycle basically represents uh, anatomy in different phases of the breathing cycle. And later on, the sorting happens at each respiratory phase and couch position. So you can see this cycle that this is the inhalation. So at each level, a set of CT images are generated during each phase of the cycle at different points, and the couch patient is moved throughout the cycle, and later on, images are acquired during the entire respiration and sorted later based upon their couch position and also related to each respiratory phase. And then for this purpose, we need a CT scanner and we need a respiratory signal device. So CT0 corresponds to end inspiration when the patient has taken a breath in, and CT50 represents to the end expiration when the patient has exhaled. Okay, so for the, as I mentioned before that, if we need a CT scanner and the respiratory signal to see the breathing cycle. So for that purpose, we could use, normally these are the systems which are used as a signal box system, which is the RPM monitoring, and the other one is the bellow system. So in signal box system, we use this device placed on the patient's abdomen, which are detected by the infrared camera. And this camera tracks the movement of basically that device and creating signals that correspond to the respiratory cycle. It is a non-invasive and more comfortable for the patient. But it also has some issues because we need to place this box at the correct location, because if we do not put this box in the correct location, so we may get false respiratory signals. So that could ultimately leads to the issues while planning process. The other one is a bellow system. It's just like a belt. It is applied around the patient's abdomen, and then the function is the same. Basically, it expands and contracts with the patient's breathing, and it provides a visual representation of the respiratory cycle. Simple to use, provides a clear, direct measurement of the respiratory motion, but can be uncomfortable for the patient sometimes. And it may not be suitable for body types. But in our hospital, we use bellow system. Regarding the bolus tracking technique learning objectives, so there are multiple protocols which are present. So we use this protocol in which we inject contrast and start taking within 15 seconds after, and then mark the tumor and then take images according to these timings. Portal venous phase and delayed phase. Usually the HCC is more visible on the arterial phase. Okay, so one 4D CT is generated and it's sent to us. So all the phases bins are sent to the radiation oncologist to see like all the phases 10, 20, 30, 40, 50, 60, 70, every. Ideally, we should mark ITV manually by controlling GTVs in all the 10 breath phases of 4D image set. It's the most accurate tool tool to determine the ITV. But sometimes when the motion is controlled, it's not that much. So usually we can also control on CT050, but after contouring on CT0 and CT50, which are the end expiration and inspiration phases, we do check on all the phases. This is our practice. And ultimately, we draw a final ID based on that. So this is a picture of the lung tumor, and we could see that because of the movement of the diaphragm, you could see that if you only draw this at this location, so when tumor is moving, we will be missing the target. So actual tumor motion corresponds to this. So we have to check in all the phases. So that is the MIP basically. MIP basically, what is the MIP? It's the maximum intensity projection image, and that highlights the highest attenuation values in a volume, and which usually this helps us to visualize hyperdense structures like contrast enhance. So these, it is more important in the lung tumors because we, in back of the lung, we have hypodense lung tissue. So it's easy to determine on those images, but for liver tumors, it may not be suitable. Only so we have to check with the minimum intensity projection images, which we call min-IP, and also use the multiphasic contrast enhanced image with the 4D CT scan for the better visualization. Because the tumor, the liver volume, the appearance of the normal liver tissue is not hypodensic. So it's very difficult to determine based upon only MIP image. Okay. So based upon the ICRU, basically, what is the ITV? Basically, it is the internal target volume. And what we do that we draw the GTV. In this case, IGTV, or basically is as per the definition, ITV is the movement that incorporates movement of the CTV. So because in the SBRT cases, we draw the gross tumor volume. So it could be the margin, the movement of the primary tumor, and we give that margin to the IGTV. So what we do, the first of all, we mark GTV on the non-gated images or average images, and also we retrospectively go and make changes according to the all phases. So in that way, we generate an ITV, and then after that, we give PTV margin based on the setup margin. We usually give around 5 mm margin. And the basic aim of like abdominal compression belt and other techniques to basically decrease this part, the movement of the GTV. So the margin of the ITV will be less if we use some abdominal compression belts or other techniques. Okay, so I will skip the slide. So what is hysteresis? Sometimes people only use 50 CT50 and CT0 to create the movement, but that is only soup and inch move if we use only these two images. But what is hysteresis? Basically, some tumors can move sideways also, not only soup and fly from P1 to P4, no. So, and post sideways, the tumor may move around it. So we need to incorporate tumor in all, we have to check the range of motion of the tumor. So that's why we also check all phases or also to incorporate the real tumor. And then we can draw the true ITV. Okay, so those learning objectives were related to the planning process. So I have briefly discussed about the 4D CT. Again, if someone wants to learn, then again it's a detailed topic. How does we do in the practice and everything? But we use 4D CT scan, and we use abdominal compression belt for institute to decrease the range of movement. So what about the target and OR doses? So these are the learning objectives related to the dose schedules, and for cholangio, HCC, and varying fractionation schedules, and strategies to optimize normal liver tissue sparing and reduce the risk of GI toxicities, and these predictors of liver toxicity. Okay, and how to manage the radiation-induced liver disease and liver compensation. Okay. So for hepatocellular carcinoma, the regimen is around 30 to 50 gray in 3 to 5 fractions. Dose really depends upon the volume of the healthy liver tissue. And all these data basically is derived from the surgical series, the healthy liver. And also we need to look at the tumor burden. Most of the literature that recommends the dose of BD10 more than 100 gray, the ablative dose that is equivalent to more than 100 gray. So usually we use for HCC 50 gray in 5 fraction, which is equivalent to BD10 100 gray. And you can see that if we decrease the dose from 50 to 40 gray, that will be 8 gray per fraction. So our BD significantly drops. So in terms of local control, when the BD drops, local control also drops. So the usual recommended dose is around whatever the dose fractionation you use. Usually is 5 fraction regimen and 50 gray, 5 fraction or more, if it allows. In terms of liver metastasis, there are multiple series. So usually, what in our situation we use 48 gray in 3 fractions. If we see the BD of that dose, it's around 125 gray. And again, it's the recommended doses, but we have to check. We have to check patients' liver volume and other parameters, OARs, and we have to respect OARs first of all, and then we have to prescribe our dose according to that. And there's a literature where if you could see this study that local control rate was increased from 50% to up to 90% if we increase the BD from 80 to 130. So in that we could say that BD 100 is the magic number. So toxicity is the name of the game, as I mentioned. Many areas we want to treat are by organs that move. We have to choose the right motion management technique to decrease the target size, and we have to maximize our BD as much as we can. And we have to deliver safely. We have to respect the OARs. Magic number seems to be around BD 10, 100. And yeah, the Timmerman tables for the OARs. This was the initial study published in 2005. I like that even with these parameters, they took two parameters. One is the normal liver, that is the minus GTV. It's the number is around 700 cc. And if we use these mean liver doses in 3 to 6 fractions, less than 15 in 3 fractions, less than 20 gray in 6 fractions. So the chances of having radiation-induced liver disease were less than 5%. Again, this was a phase 1 trial that was published quite earlier in 2000. And I like this diagram that if we do not have a free liver volume less than more than 700 cc, so I think those are the patients who are not candidate for SBRT. Also, we have to incorporate child progress score and other parameters which I discussed last time. So in terms of liver volume, 700 is the number. More number we have like this, so it's easier to treat with SBRT and respect the OARs at the same time. And in terms of size, again, it's more about the liver volume, but RF and SBRT both are very equal effective as per the data up to 3 centimeter tumor, but SBRT has more advantage for those tumor who are located near the vessels, and also when the tumor size increases from 3, the RFA chances of control are decreases usually. And but even for the SBRT, if you are treating more than 5 centimeter, the local chance of local control decreases with the size. So it's more about the volume now. So in terms of OER, we usually follow the Timmerman table, and also for the liver cancer, the RTOG 1112 that was presented in this astro. And you could see that in this trial, which is a randomized phase 3 trial, the sum of diameters was median was 7.8 centimeter, and the maximum was 19.1, and the 74% patients were with macrovascular invasion. So again, if we could save the liver volume and we can control, if we can control the mean liver doses, so we can offer SBRT easily. So this is, we follow this one that in this protocol they use the 5 fraction regimen, and prescription dose was covers the 95% of the PTV, and the normal liver, which is the liver minus GTV, the prescription was based on that. So we have to, if the normal dose is 50 gray in 5 fractions, and maximum mean liver dose allowed is 13 gray. If we are not able to achieve that, we have to decrease our doses, like go to 45 in 5 fractions, then go to 40 gray in 5 fractions. And if you are not able to control the corresponding liver doses, we have to decrease our doses accordingly. So we use that as Timmerman tables and the RTOG 1112. So plan evaluation, we all know this great mnemonic, that is CB chop, contouring. First of all, review the target volumes and OARs. Then we have to check the beam arrangements, or in this case, now in VMAT we use check the arcs arrangement, and are they appropriate and reasonable. And then coverage on the east slices, and then go back to deviation, evaluate it, and then check the heterogeneity and hotspots inside it. And then we look at into the organ risk, and then what is the prescription dose. So this is the mnemonic to evaluate the whole penetration. And the other slides, learning objectives are related to SBRT patients with prior renal transplant. What are the challenges of follow-up imaging? New liver lesions appear on the follow-up image. Okay, I'm going to discuss few cases, so most of the learning objectives will be covered on those cases. So again, it's challenging sometimes. We cannot comment immediately because sometimes liver takes time. You can say according to this study, even after 4 months, you could see the appearance was not that good. But with the serial imaging, we can see that there's a response. So it's challenging sometimes, and we need to follow patients regularly. We usually do 3 to 4 months MRI. Okay, so the main learning point is, okay, the MDG team, we need good RTTs in addition to radiation oncologists, medical physics team, and we also need to deliver that high dose, because it's a very high dose of radiation, and we have to safely treat the patient. So we need all the personnel. Now I will review some cases. Do you see my screen?
Yes, Muneeb, we can see yours.
Do you see my screen now?
Mm, it's just a screen which shows case 1 metastatic disease, and your cursor is also
Yes.
moving.
Okay, fine. Okay. So this was the case. So 36 years old male initially presented with abdominal pain, and the CT scan showed a large heterogeneous mass in the pelvis. So he underwent resection of that mass, and that showed just gastrointestinal stromal tumor. And he started with adjuvant imatinib in 2020, 4 years ago. And after 2 years after that, the PET scan, follow-up PET scan was done that showed multiple new liver metastases. And the medical oncologist increased the dose of the Gleevec after that. And in January 2023, he underwent resection with negative margins for basically the metastaectomy. And he underwent resection of the segment 4B and 7. And left lateral segment resection, and then he was continued Gleevec, and his scans remain stable. Last year, in June 2024, so most of the scans lesions will remain stable, but there was a continued interval growth of segment 5 lesions, and you can see the serial imaging on that this lesion was continuously growing. So this time the patient was referred to us for the consideration of SBRT. We recently got this abdominal belt for testing purpose, just like a big blood pressure cuff. It's not that, but because it was, we found it was easier to put on the patient, and it takes less time compared to the large backlog with all of the plate R shape. So we used this first time in this patient, and it was a metastasis. So we prescribed a dose of. Our aim was to prescribe 48 grain, 3 fractions every other day, and we control the GTV and on all the phases. Then we create IGD and then margin with 5 millimeter set of margin. In terms of liver controlling, as I mentioned, that we control the liver minus ITV as the primary liver structure as an OAR, and we remove all other cysts from that. So after excluding all those things, so our final liver volume was more than 1200 cc. So it was good to go. And this was our prescription sheet. We prescribed 48 gray in 3 fractions. This was our aim, and the sheet was going for medical physicists. So I'm going to show you this video. Let me know if you can see the video. Can you see the video?
Yes.
Okay. So if you look at this images, we did the MRI sim. We have MRI in our department, so we did the MRI also, and at the same time CT, and we did the fusion. You can see that these we planned on the GTV, and the blue one is the ITV. These are the two pins, 0 and CD50. We have to check and manually change the contrast in our screen to best identify the tumor in all the phases. And this is the movement of the patient 4D scan. You can see the movement is quite minimal. Okay. Mm. These are some images of the plan evolution snapshots, and you see that the coverage of the tumor and the dose fall off. So if you look at one thing is the bowel, this is the colon, small bowel, kidney. So again, the fall off with as the aim of SBRT planning is to deliver high dose. At the same time, we need a sharp fall off from the tumor. So after the PTV, so it's quite easy. Well, it was easy. It was good plan to deliver for the patient. The other organ risk considering in this case is also the chest wall. We have to draw individually draw the rib and put a constraint on that. So these are the DVA that represents this patient, and if you could see that our prescribed dose was 48 gray, you can see that our coverage was quite good, and this blue one represents on ITV. It was getting a higher dose, basically to more than 50 gray. In terms of liver, our mean liver doses was 4.1 gray in that case, and we have to the critical check. We have to check the whole liver volume more than 700 cc. So it's the liver minus ITV in our case, and as per the tables and mean liver doses, we have to respect that. Okay, so this patient was followed, and we on the first follow-up scan, we found that it was reported that another oligoprogressive liver metastasis in the segment 7. If you look into these images, these are highlighted over here, marked over here. This one, this one, this one. This is the same patient which we treated. So retrospectively, we went and see. So there was some enhancement that was not reported at that time. So this patient was treated in August, and then on the follow-up imaging, we saw another 2 lesions that were further growing. So we decided to treat those lesions again. So our prescribed dose was same, 48 gray in 3 fractions every other day. And this time our liver volume was around 1100, more than 1100 cc. And in this plan, we exclude the area that was treated. So we have to really care about the normal liver tissue. We have to respect that in order to reduce the side effects. I'm going to play this video of this patient, second plan. So you can see so those 2 GTV were marked along with ITV with the help of the MRR, and basically at the end they were quite close to each other. Both. See the GTV side, and you check on the sagittal image. And this was the area that we treated. You can see the halo of our SBRT, and this was the region treated, and you can see our dose, the isodose curves. That is representative of isodose curve. Basically, that halo. So this is a coverage of the tumor, the prescribed dose, the dose color wash, and let's see how the dose color wash. Yes, I think so. So in this case, the total overall critical volume as per tumor tables should be less than 17.7 gray. So we have to calculate the whole liver volume as I mentioned, and the mean liver dose in that case was 4.1. So this was re-radiation, basically the same patient with another plan of radiation. So we have to ask for the plan sum in this case. In both scenarios, we delivered the same. Our prescribed dose was same. That was 48 gray in 3 fractions in the August, and in the November also 48 gray in 3. So we asked for the physical plan sum dose. So even our liver critical volume was adequate, and our mean liver dose was overall 9.4. Okay, so this was a case of the liver metastasis that I treated. Yeah. So this is the case of hepatocellular carcinoma, and this 66-year-old gentleman who was treated with HIV in 1988, and with the hepatocellular, HCV virus, he was treated and eradicated, and he presented in 2019, and at that time he was 66 years of age. Before coming to us, he had a few sessions of RFA, and also he had a session of TACE, transarterial embolization, for the HCC. And when he came to our hospital in our radiation oncology department, he was checked for all of the investigations. So I saw the picture at that time, 5 years ago. So he was treated with this arch-shaped abdominal compression device. We don't use that anymore now. So this was you. This is a patient's picture, and I reviewed his previous plan at that time. So he was at that time there was a fiducial placement, and he was planned for 50 in 5 fractions. So you can see this area. This is the TACE area. He was treated with for the TACE here, and this was his liver. This one looks good on the left side, but the right side liver you could see some erotic appearance, and this is the fiducial that was placed at that time. And this is the MR. You can see the appearance of the liver, and I saw that almost 5 years ago, this was marked as a GTV. Definitely, this must have been discussed with the radiologist and considering all the imaging. And at that time, I think the practice was to just mark the GTV in all the phases and comment changes. So this was the area that was treated with 50 gray in 5 fractions in 2019. And the prescribed dose was 50 gray in 5 fractions. See, this is the chest wall as an OAR, and also the coverage of. So the liver in 2019, the liver volume was free liver was 1500 cc. So as per the protocol, it should not receive more than 17.5 gray, and it was achieved. Basically, he received very, this is brown color represents the liver basically, which is not absolute volume. So I don't have the picture, but you can see the coverage of the volume that 49 gray, almost 49% of the volume, and this is the GD basically, close to 60 gray. So last year, after 4 years, of follow-up, he was again sent to us, and he was not receiving any treatment. For as a follow-up imaging, there was a lesion that was grumbling, and as for the radiology, it was a layer 4. So we planned last year this patient. You can see that taste related changes, and our treatment volume was there, and this was the ITV based upon our imaging. MRI. And this was .ptv marked. See slide movement here. Okay, so if you look at this picture, this is a normal liver that was drawn, and you could appreciate that we removed the previously treated area from our normal liver contour because there's a non-normal tissue there. This was treated with RFA, TACE, and radiation. So there's a non-normal tissue left. So we have to exclude that area from our normal liver, and then we have to calculate our normal liver volume. So this was the plan, and you can see that 12 gray lines isoscope. And this was the deviation, basically. So you can see that the 50 gray lines covering close to 100%. This was the deviation. And again, we asked for the sum plan. Usually, when we use different fractionation, so we also ask a plan of is in terms of EQD to two for fraction, then we evaluate accordingly. So liver mean dose was 5.69 in that case. So last case review, 52 years old lady with very good performance status. When we saw a few months ago this lady in September or August. So initially in 2021, she was treated with a new adjuvant chemo and pelvic radiotherapy for primary rectal cancer with 25 fractions, and then followed by lower anterior resection in 2021. She developed, she had metastasis, and then she underwent right liver trisegmentectomy and cholecystectomy in 2022, and subsequently right liver resection and APR based up because she had a local recurrence and lymph nodes. So she ended up in colostomy after 3 years. So and then she received chemotherapy and multiple courses. So recently, also after that, sorry, it was July, yeah, 2024, and also in 2023, she had RFA for a liver lesion. And when she was sent to us, she had two oligoprogressive disease in her body. One was a metastatic nodule in the anterior abdominal wall, and that was resected by the surgeon, basically. And she was sent to us for this lesion that was growing the liver. You can see that her liver is the left side liver. It's a different position because her right liver has been removed by the surgeon. So this was the lesion that was growing in the liver, and she was sent to us for the SBRT evaluation. So the blue one was our ITV, and the yellow one is GTV, and then ITV based on the movement of the GTV in all the phases. Okay, the question, if someone can respond. So, what dose do you expect to deliver in this case? I will show you the plan. Can someone comment if what dose should we give to this patient? Any idea? Okay. So, because if you look at this location, so this comment, let me check. Agree. Dr. Ali has mentioned the 30 to 40 in 5. Yes. Yeah, because if you look at the location of the tumor, it's quite close to the stomach and the bowel. So we have to respect our OARs as well. So in this case, so we prescribe low dose. If you look at the Timmerman tables for the 5-fraction plan, you could see the maximum point dose of the stomach is around 35 gray, and also the duodenum. So we have to respect our OARs. If we prescribe higher doses over here, so we will not be able to spare our OAR. So, and this was the rationale that we prescribe those 35 and 5 fractions in this case. And her liver volume was borderline, like 1000 cc. But it was a good plan, and we were able to deliver that dose. So mean liver dose was 2.7 gray, and our stomach dose, maximum dose was 34 gray. But if you look at this yellow one, this was our GTV, so it's getting more than 35. So this was our PTV red one, and the ITV, and then GTV. One question I think people asked, and I also had in my mind when I started treating over here in my limited experience, was the placement of the fiducials. So when this program was started at McGill, as per the faculty, they used to put fiducial in all cases. We have a cyberknife over here, but they do not treat this patient with cyberknife. And as per their experience, sometimes when we put cyberknife, there are some pros and cons of both every technology. You have to gauge on which machine you can treat easily. Cyberknife, we cannot do CBCT, we cannot see the lesion, but we can put 3 fiducials there. But there are chances in the liver that their fiducial may displace, so then you will not be able to know clearly know on the machine that if they are displaced fiducials or not. So based on our faculty experience that they used to put fiducial initially, but after the COVID, patients were quite reluctant to go for the surgery because fiducial placement is an invasive procedure. And through the learning curve, our technologist and our physicist and with the use of all technology, they were quite confident. So after the COVID, all the liver cases usually are being done on without the fiducials here. And again, this could be a question that in my why are we not putting fiducials? But in my opinion, what I have learned that if we are starting a new setup and if we have a new team, so we should start with fiducials first, and then by the learning curve, if we feel confident, then we can exclude fiducials. So this was some cases I wanted to share with you. So if you have any questions, please, I will try to address as per my capacity. Thank you.